fluids and perfusion and a lot of things over the last couple of days. So try not to repeat myself. I will try to put together some of the key messages in this talk. And I'm going to show you some of the things that you can find in terms of the management of shock in these consensus that was published by the European Society of Intensive Care Medicine, and indeed Daniel De Backer and Jean-Louis de Boule are some of the co-authors in this. And of course also the latest Surviving Sepsis campaign with some recommendations from this. Now, when we talk about septic shock, I think the most important thing to realize is that it's not just about supporting circulatory failure. It's a circulatory failure that is related to the fact that we have an infection that is causing organ dysfunction, and that's sepsis. So it seems obvious, but I still see sometimes in my practice that we sometimes have to fight maybe with a surgeon or with a radiologist actually to say we really need to try to have source control for this patient. Sometimes knowing that there is an abscess or there is a laparotomy to perform, maybe that's the most important thing. That's really what's going to make the difference for that patient. And stabilizing that patient does not mean that we have to delay source control. I know that when the committee was trying to give a recommendation about this, they were even trying to put some time in this and to really try to force things, but they had to take probably a pragmatic approach. So if you read this, it basically says, we recommend that a specific anatomotic diagnosis of infection require emergent source control be identified or excluded as rapidly as possible in patients with sepsis or septic shock, and that any required source control intervention be implemented as soon as medically and logistically practical after the diagnosis is made. I don't even think that we will ever need to do a randomized control trial about this. I think this is just best practice, right? So we should just do it. However, I'm sure that you have examples also in your practice. Sometimes we have these conflicts about how to try to get this done as soon as possible. And I really think it's one of the things that makes a huge difference for this patient. Cornerstone of the therapy, and there are studies, for instance, that show that starting antibiotics late from time 0 is associated with worse outcomes. Some people may argue that the study looks too good to be true, but I think there is definitely a signal there. Again, if we are treating an infection, we should fight the infections. That means source control, but also means a proper antibiotic cover. And the antibiotic cover needs to be started really as early as possible. So the administration of a V antimicrobial needs to be initiated as soon as possible and really within an hour. I can guarantee you, and I will show you some data later, this is something that we think is just common sense. If we look and we audit in our practices, still sometimes we fail to achieve what just seems to be common practice or common sense. And of course, when we start with antibiotics, at the beginning it's very rare to have the precise bug that we are treating, so we may have to start with broad spectrum antibiotics depending on the local resistance and the local prevalence of bugs where we are. So I will try to explain maybe some of the rationale of the bundles of the Surviving Sepsis campaign. These are some of the badge cards that they suggest maybe to use in the emergency departments and so on, where you can put the name of the patient and just say this needs to happen within 3 hours and within 6 hours. I tell you my view on this. I think as a safety net, this is okay if you don't have anything better. However, I think we can be a bit more sophisticated than this, and probably we should be a bit more sophisticated than this if we are in an intensive care unit. So yes, if I'm in the emergency department, I need to take every single patient in which I think that there is sepsis. Measuring a lactate level is important. What I do with it, I think it's even more important. I'm not going to debate about this because it just makes sense to take blood cultures before giving antibiotics and to give broad spectrum antibiotics. If you were at the live debate that I just shared with Jean-Louis Vincent, Yann Deval, and Sangunna, we were talking about vasoactive drugs. And I think when we looked at the septic shock, it means that very often there will be hypotension in that patient. This concept about starting 30 milliliters per kilogram of crystalloids to try to treat hypotension within 3 hours, again, if we don't have anything better than that, that's okay, but a patient that is hypotensive, and I think that's a message that we try to pass more and more times over the last couple of days, and in the case-based discussions also, I was pleased to see that it's coming. Remember, in real-life practice, sometimes it's just not feasible to wait for the fluid to work. We may have to start both things together, so we may have to start a vasopressor anyway. And that's why I think I sort of disagree in the way this is written here. To be completed within 6 hours, I would say apply a vasopressor as soon as you realize that the vasoplegia is so prevalent as a component in this shock that fluids may not be enough to restore along hypotension. Of course, then there are other things that make a lot of sense to me, and we will talk about some of this soon. In the event of persistent hypotension of the fluid, again, you need to reassess tissue perfusion. This to me is just best practice. We need to do it continuously. I would argue we have to do it in these very sick patients every 15 minutes when we do something different, whether it is a fluid challenge, whether it is a change in our adrenaline dose, whether we are now deciding to ventilate the patient, and so on. And of course, assessing what we are doing, not just in terms of macro hemodynamics, but having some idea of what's happening in terms of a marker of perfusion. And so re-looking at lactate, it's one thing that makes a lot of sense. I often, when I talk about shock, I like to talk about this slide because I think it's a study that is quoted, but maybe not quoted enough in the sense that I think it has a very nice story here. It's not a problem of hypoperfusion only being the most important thing, or it's not a problem that only hypotensive patients are the sick ones. There is clearly a spectrum. There are different phenotypes in the patients that we treat with sepsis. So I could have patients come into the emergency department with significant hypotension, but sometimes maybe not with a very high lactate. Still, being very hypotensive means that these are patients that are still associated with a significant mortality. And this is important because, yes, I can have shock even without hypotension, but at the beginning it means that every time I get a patient with hypotension and I don't know anything about that patient, I should treat that as an emergency. I can do fine-tuning of my thinking later on and start to think maybe that patient requires a lower blood pressure, or maybe the patient is fine with a lower blood pressure, but not at the beginning. Not at time 0 when we receive this patient. It's not the moment to do sophisticated thinking. Hypotension, a de novo hypotension, in my mind, it's an emergency. It's a medical emergency. We just treat it. We try to go to a safety area, maybe of 65 millimeters of mercury. I think it's a sensible approach at the beginning. And then we will start to individualize what we are doing. You can look at these axes on this graph on different ways. So we can have a look at the patient with a normal blood pressure and a low lactate. Then, of course, is that patient in shock? Maybe not. Maybe just had a syncopal episode and now is recovering. But patients that have normal blood pressure, or what we consider a normal blood pressure, and still they're able to show that there is significant hypoperfusion as demonstrated by high lactate, these are patients not to underestimate. I wouldn't send this patient to the ward without making sure that the lactate is on a downward trajectory. These are patients that are still associated with a 15 to 16% mortality despite being able to maintain some degree of vascular tone. And of course, the synergy is really obvious when you go to the sickest group of patients when we have vasoplegia and hypoperfusion. These are really those sick patients that have mortality higher than 50%. I think they should be in our units. I think they should also deserve more sophisticated approach just than measuring a lactate and probably having ultrasound and maybe some more advanced hemodynamic monitoring. So what is the recommendation? I think the recommendation for any shock when we receive a patient with hypotensive should be really this one, and that's what we basically said, is that if we understand that there's a problem of hypoperfusion, hypotension is often one of the clinical signs that will make it apparent. Often it's the reason why we're called to see a patient. So hypotension is often very present, but it doesn't need to be there. So it means that we can still have patients that could be in shock even with a normal blood pressure. And well, how would I identify that? This morning I was talking about the importance of clinical examination in that. Well, the diagnosis of shock is still a clinical diagnosis. I have several windows that I can explore: the mental state of the patient, the skin, the mottling, the temperature, whether there is urine output or not, and of course blood pressure and heart rate. So we were talking, and Daniel was talking before about the norepinephrine, and we were talking about this even in our live debate, and I would argue that in septic shock there is really no role for dopamine at all, and I would argue that probably there is a strong evidence to say that norepinephrine should be our starting vasopressor. I can't see any reason why I would start any different vasopressor, unless you are telling me that you are in the very initial phase when you are only have a peripheral line and you need to give maybe phenylephrine until you put a central line. That's okay. But when we have a central line and when we have our infusions going, I think norepinephrine should be our gold standard in terms of vasopressor use. Interestingly, this is an observational retrospective, a series published by the group of Hannah Wunsch. In America, there was a shortage of norepinephrine at some point, and they found out that those hospitals that were not able to get enough stock of norepinephrine and therefore they started to use more phenylephrine and other vasopressors, they found out that they had a significant increase in mortality during the time period. Whether that it's a cause and effect just caused by that, or maybe by the other organizational issues, and maybe not being able to reach for norepinephrine was a marker of how bad an hospital was, I don't know. But certainly there is some food for thought there, and as I said, I think it should really be our vasopressor to start. What should be the target? The real target is really something that probably needs to be individualized for every patient. But we have some data that shows that above 65, maybe there are some group of patients that may benefit for something more. This is a study from Asfar, and Jean-Luc Teboul was one of the authors of this paper. They were randomizing patients to be randomized to a lower MAP and to a higher MAP. Interestingly, both studies, in both groups, the measured MAP was much higher than the MAP that the clinicians decided to put as a target at the bedside. So, and that tells a story that very often we overshoot a little bit with our therapy. It's not necessarily a bad thing, and that means that probably when we say 65, it's enough to go on a safety area for our patient if we achieve that. The primary outcome of this study was mortality, and there was no difference in mortality whatsoever for the two groups. However, when they started to look at secondary outcomes, they found out that patients with chronic hypertension, they had less acute kidney injury. They also had, the ones around on a higher blood pressure, more arrhythmia. So I don't think you can say that every patient that comes with hypertension should be started on a much higher blood pressure target. But certainly those patients in which we know that there is a history of hypertension and maybe we see that the kidney function starts to deteriorate, maybe those are those patients in which I tend to go a little bit higher than the usual 65, and I tend to protect maybe the autoregulation of those kidneys maybe a bit more. I think autoregulation is really where we are failing at the moment in terms of understanding where we are. We have probably are a bit more ahead in neuroanesthesia, neurointensive care. It's a concept that we've developed for many years, and we have some ways to try to estimate the autoregulation points and range of blood pressure there, but it's the same concept for any other organ. I think what happened with the classic MAP of 65 as a threshold, it means if I take a normal distribution of a population, probably for the majority of us, running at 65 is probably okay to stay in the autoregulation range. But there are certainly a group of patients in which this is not true, and therefore if I am chronically hypertensive and I run on a diastolic blood pressure more close to 100 than to 80, probably 65 is not enough, and I really start to have a decrease in my renal blood flow. This could be one of the explanations. I suspect some future research will try to identify some variables that are allowing us to identify the best autoregulatory range for our organs. Apart from vasopressors, and I will not go into the detail of all the other vasopressors that we can use, because unfortunately there is not much evidence to say the other one, whether it is vasopressing or angiotensin II, they are much better one than the other. We don't talk about steroids as a vasopressor drug, but the effect that they have is the one also to increase blood pressure. So there have been a couple of big studies that came out recently on the New England Journal of Medicine. The largest is the adrenal study published. It's a multicentric study run by the ANZIX group. The primary outcome was a difference in mortality, and I couldn't find any difference in mortality in the two groups. However, the side effects for hydrocortisone compared to placebo were very small. As you know, one of the side effects that was considered to be a danger before the study potentially was the critical care myopathy, and even if it was a little bit more prevalent in the hydrocortisone group, it didn't reach statistical significance. What they found is other secondary endpoints were actually better in the hydrocortisone group. So the time of resolution of shock, time on ventilator, even discharge from the ICU. And I believe that those are important outcomes for our patients, so I think it's strong evidence probably to say that when we are happy that we've given enough fluids, that we've optimized the cardiac output, and that we are now on escalating doses of noradrenaline, and this is not enough, probably that's a good moment to start hydrocortisone. Not high doses, we're talking about 200, 250 milligrams of hydrocortisone in 24 hours. What about understanding where we are and how we can assess what we are doing, whether it's being given fluids, whether the vasopressor, whether sometimes we want to start an inotrope? Well, for many years we thought that the SCVO2 after the RIVER study was going to give us that answer, and as you know was also in the recommendations of the first Surviving Sepsis campaign. When this approach was tried though in multicentric studies, unfortunately all of these studies, they failed to show any improvement in outcome for an early goal-directed therapy management guided by the SCVO2. I would argue, however, that the studies that replicated rivers were now looking at different populations. If you remember, one of the goal really of the goal-directed therapy according to rivers, apart from the bundle of normal macrohemodynamics, was trying to improve the cardiac output in a way that the SCVO2 would have been above 70%. But if I look at the baseline for the ARISE study, this was already 73%. For PROCESS was 71%, and for PROMISE was 70%. Now, it becomes obvious that if I have a protocol that is telling me to go above a threshold, if I'm already reaching the threshold of baseline, then the protocol is not doing anything different compared to my standard of care. Interestingly, the RIVER study had a mean SCVO2 of 49%. I don't think RIVERS was lying. I suspect the story that is telling us here is that after RIVERS, we started to understand more and more, also with some of the campaigns that were made, the concept of early recognition, early treatment, early filling of the circulation. So by the time we receive a patient now in our emergency department, I think we are much more aware of the concept of septic shock. So in a way here we were testing rivers against rivers. We are now testing a group of population of patients that is much better resuscitated when maybe we stick a central line. To me, it does not mean that the central line is useless. It does not mean that the SCVO2 is useless. It just means that we have to understand where we are in terms of oxygen demand and oxygen balance for these patients. So if I look at how the SCVO2 works, it's a formula that can look a bit complex, but what it means is that some of the variables that are on this part of the formula are actually, they have a non-linear relationship with the SCVO2 increases, while some other variables will have a linear relationship. So for my oxygen saturation, very often I will have very little room to improve unless I have a very hypoxic patient. And the opposite is for cardiac output and for hemoglobin. So very low values of cardiac output will be associated with a very low SCVO2, and very low values of hemoglobin will be associated with a low SCVO2. So the maximum benefit is usually in this part of the graph. It is here that I will see the biggest benefit and the biggest increase in SCVO2. It does not mean that I cannot increase cardiac output here and still improve my delivery to the tissues. But the SCVO2 will become blind at the stage because I have reached values probably already around 70%. And one of the problems of the SCVO2 is that after I reach those values, it becomes blind to what happened to different areas of the microcirculation. So I could have areas that are completely shunted, and therefore they will give back to the venous blood almost 100% oxygen. Those are areas that still require oxygen, they still require energy, but they will have to produce energy in an anaerobic way. They will produce more carbon dioxide. And so if I mix all the blood before my heart, I may see that the SCVO2 is absolutely normal because I'm blind to these areas of the microcirculation. One of the things that is being proposed is to look at the increase in carbon dioxide difference between the arterial and the venous blood, and therefore a high CO2 gap is considered to be a mark of an inadequate perfusion for these patients, even when the SCVO2 is already high. So, to conclude, what the bundles of the SEC say then after the initial first hour and 6 hours bundle, but they said repeat a focus exam after fluid resuscitation, including vitals, cardiopulmonary recovery time. I'm surprised we need a bundle to say this. I think it's the core of our practice, but I don't disagree with any of the things that are said. Measure CVP and measure SCVO2. I think it's more important what we do with these variables. I would argue that ultrasound, probably at this stage when we have decided to take a patient into our unit, it's a crucial part of our clinical examination. At least a basic ultrasound is something that I think needs to become part of our way to manage all patients in shock. We don't need to become super experts, but we need to have an understanding of some basic views as a point of care testing. We shouldn't be asking for an echocardiography examination and receive the examination maybe 2 or 3 hours later. And of course, we can use different type of monitors then to monitor what we're doing. I'm just showing you a couple of slides because I don't want you to misinterpret what I said about the bundles. I think we need to individualize therapy, and having a physiological approach to this patient is very important. But I do believe that having bundles in place to try not to miss patients falling through the net is also important. And for instance, with the IMPRESS study, we looked at what happened to institutions, whether they are compliant or non-compliant with the 3 hours and the 6 hours bundle of the Surviving Sepsis campaign. What you see is that there is a clear difference in mortality between the institutions that are compliant or not. Is it the individual component of that bundle that is making the difference? I'm not sure. But the story that is telling me here is that I'm working in an institution that has a culture about recognizing sepsis, about treating sepsis early. Same thing was demonstrated by Seymour very recently, in which he found that, again, delays in starting antibiotics and therefore in being non-compliant with the 3 hours bundle of the previous Surviving Sepsis campaign was associated with an increased mortality. So to conclude, I think this is true for any shock state, but in particular for sepsis, really the problem there is really perfusion. We can use different strategy to optimize this patient. The fact that there were some negative randomized control trials to me is not a reason to forget physiology. We have opportunities in bundles and in checklist, and I think that some of these patients do benefit from some extra monitoring techniques that can give us some extra information about physiology to individualize their therapy. Thank you.